Hello, good evening again. So, osteoarthritis, talking a little bit more about risk factors. So, who tends to get osteoarthritis, or otherwise known as wear and tear arthritis? So, as mentioned last video, this is a degenerative joint disease. So, it attacks the cartilage that's in the joints, and it's one of the most common joint disorders. Again, at least 20 million Americans affected by it. And so one of the differences between osteoarthritis and some of the more inflammatory arthritises has to do a little bit with the degree of inflammation. So yes, there's inflammation in both different types of arthritis. So the things like the Sjogren's and the rheumatoid arthritis and psoriatic arthritis and so forth. Yes, there's a lot of inflammation, and so a lot of the things that I just mentioned in the last video may very well also, actually, I know they do apply to the inflammatory characteristics as well of the inflammatory arthritis, but there's also is some inflammation. The osteoarthritis is just kind of a degree of difference in it. And the other difference too is that with some of the inflammatory arthritises, sometimes the entire cartilage can be destroyed and the joints twist and do things. That can happen to some degree too in the osteoarthritis, but it doesn't tend to be quite as severe as in the rheumatoid arthritis if it's not well controlled. So, alrighty, so most cases of wear and tear arthritis occur on their own. There is not necessarily a predisposing disease that causes it per se, but there are some medical disorders that tend to predispose a person to getting that wear and tear arthritis. So endocrine abnormalities like low thyroid, high thyroid, diabetes, and so forth, and some of the other joint diseases. So you can get an inflammatory as well as a wear and tear arthritis all at the same time. Gout can also lead to osteoarthritis as well in the affected joints. Basically, anything that causes inflammation or damage to the joint can lead to that wear and tear arthritis. So Brooke is asking, how are the different types of arthritis diagnosed? Well, good question. It has to do a lot with the history and physical exam, and sometimes some blood work as well. So if something is a very common joint, such as the knee or the hip or the base of the thumb, for example, is a very common osteoarthritis, and sometimes the fingers if you're in a job like a lot of us are these days involving computers frequently. You can tell a lot from just looking at the joint and feeling it and getting a history. How long has it been going on? What time of day are the symptoms worse? If someone's got an inflammatory arthritis like a rheumatoid or Sjogren's or psoriatic and that kind of thing, then the joint is going to be mostly symmetric swelling in a lot of the different kinds of joints, although that can vary, if it's a lupus or something. That tends to have a migratory arthritis, like one day one joint's affected and then hours later another completely different joint can be swollen and sore. But osteoarthritis tends to affect like more one joint over another, like maybe focused on the knees or a hip or something. The inflammatory arthritis, a key characteristic is how long does the swelling and inflammation last. So if you wake up and first thing in the morning you get some swelling and soreness, and that stiffness lasts for over 30 minutes, that tends to be a better marker of more inflammation. So again, these are all things to for sure discuss with your own personal physician and kind of sort out the characteristics of your personal situation for sure. But good question. So if someone's got these other joint conditions that cause trouble, for example, the rheumatoid arthritis, you're welcome, and gout and so forth, those extra inflammations will tend to predispose those joints to getting that wear and tear arthritis over time as well. Another thing people sometimes don't think about as much is that trauma can cause wear and tear arthritis to be more prevalent in that joint. So I frequently have seen people who've had a bad injury, like a twist to their knee, and then over time that tends to turn into more arthritis on that side versus the side that did not have the bad twist in the knee, or car accidents, or sledding accidents. I mean, all sorts of different kinds of traumas that can happen. There is a post-traumatic inflammation that can happen, and those joints tend to get more crunchy. I call them basically more of that wear and tear arthritis. All right, and then there's also some bone diseases. So if people have poor blood circulation, especially to the hip, something happens called avascular necrosis. So that's a big, scary Latin-y word, basically meaning that the blood vessels that are going to the curve of that hip bone, so imagine a skeleton, that little bone poking out to the side, before it goes down towards the knee. It's October right now, so plenty of skeletons floating around in the stores. But anyway, if you look at that knobby part of the hip, that's a very common place where sometimes the blood supply just doesn't really get out there very well, and that lack of blood flow to the point of the hip causes the hip to wear away a little bit more. And it's called avascular necrosis, and it can cause a very, very painful hip as well, and Paget's disease. So anyway, there's other bone diseases that specifically can predispose people to getting osteoarthritis, but most of the time, none of that is around. Although these days, maybe some more of these things are being more common than they used to be at the time of this article I'm reviewing. So other risk factors, so as mentioned in the previous video, obesity really raises the risk of osteoarthritis in the hip and the knee especially. And again, has to do with that pressure, extra bit of pressure over time tending to cause trouble to those weight-bearing surfaces. Age. So wear and tear arthritis is very rare in the younger folks. And again, Brooke, that's another thing they can use to differentiate. The inflammatory arthritis most commonly is diagnosed between ages 20, 30, 40, something in that earlier category. Younger than 20, it's more commonly called juvenile arthritis, whereas the osteoarthritis tends to be more in folks who are 50, 60, 70, and the older you go, the more likely it is that you're going to find some of this crunchiness in the body as a result of these things over time. So age. So a third of people over age 65 have some evidence of wear and tear arthritis in the knee on x-rays. So again, someone coming in at age 65, oh, my knees are aching, almost guaranteed to have some form of osteoarthritis unless there's other stuff going on there. So yeah, so over a third of people over age 65 with the wear and tear in the body. Females, we are a little bit more risk for getting osteoarthritis than the guys are, unfortunately. Maybe just having to do with the structure of the body. Our hips tend to be a little bit wider apart, maybe just putting a different angle of pressure on the knees. For whatever reason, women tend to be a little more susceptible to this. Occupation. Hands, hips, and knees are vulnerable for occupational stuff. So I get a lot of people who do mechanic work and are using their hands a lot. Maybe they're carpenters, maybe they're construction workers. They tend to get wear and tear arthritis more in the fingers and the wrists, and sometimes in the spine as well from all that lifting and such. Genetics, a identical twin of somebody with hand or knee arthritis, double the risk of getting the same condition compared to a fraternal twins. In other words, identical twins have the same set of genes, and then through their lifestyle, they either turn those genes off or on slightly differently, and they tend to get very similar diseases over life, whereas the fraternal twins, those are the ones that do not have the same DNA sequence, they just happen to be being born at the same time. So they have less comparison of things. So trauma, again, repetitive tasks increase the risk. So if you're doing the same thing over and over and over and over and over and over again, that will lead to more inflammation in that particular joint and more risk of arthritis later on. And then again, pre-existing or anatomical joint abnormalities. So sometimes folks with a pre-existing joint deformity will get more wear and tear arthritis in that joint. So again, diagnosis, medical history, and physical exam. For osteoarthritis, there is no specific lab test that can be done. Occasionally, you might order a check for a SED rate or a CRP or something to check for levels of inflammation, but it really is not needed for osteoarthritis. That's more if you're looking for the inflammatory arthritis. And sometimes we do an x-ray of the area. So again, weight loss, low impact exercise, physical therapy, and sometimes shoe inserts can be helpful for knee arthritis. I've seen cases where somebody had an arthritis in the knee and it tended to be a little bit more wearing on one side of the knee than the other, and they got some shoe inserts that kind of just slightly changed the position of the knee, and then there was a lot more movement and less pain as well. So usually, the shoe inserts, that was podiatry going in. Some of the over-the-counter medicines, as mentioned last one, the Tylenol, NSAIDs, glucosamine chondroitin, I did not mention in the last presentation. I've seen some folks have done very well with it. Generally speaking, that's an over-the-counter supplement, which I know I usually don't recommend over-the-counter supplement kinds of things, but sometimes the glucosamine chondroitin done 2 or 3 times a day for a period of 3 to 6 months or so sometimes can lead to some relief of the arthritis in the knees and hips especially. Also, I forgot to mention in the last presentation, caspacin cream. So this is good stuff. It is basically hot pepper cream is where we get that caspacin. So caspacin is the thing that makes hot peppers taste like hot peppers, has that heat at you. And so when that is rubbed over a joint, it creates a sensation of warmth, and it also can reduce the inflammation and pain. The key point with this, again, is if you use it, make sure that you wash your hands thoroughly afterwards before you touch the eye or before, for example, using the restroom, because that hot pepper cream, if it gets onto a delicate mucous membrane, ouch, can cause some trouble. So you do not want that in your eyes or other delicate locations as well. So, all right, joint injections, as mentioned, can be sometimes helpful for short term, but may also lead to longer term wear and tear. And surgery, the joint replacement surgeries are reserved for severe cases. Part of the problem with that is that the artificial joint does not tend to last forever. It lasts for maybe 15, 10 years, something along those lines, and then you got to replace this silly thing. So they're going all the way back through surgery. And the other thing is that some of the more recent studies are suggesting that the exercise and lifestyle changes and so forth are actually more effective in the long run than the joint replacement surgeries. So again, something to discuss on a case-by-case basis with your personal physician as well, just trying to pique that curiosity. Basically a low-fat, high-fiber diet plus exercise is very, very helpful lifestyle intervention to help with reducing the disease process for that wear and tear arthritis. And when talking about the glucosamine chondroitin, Dr. Barnard on Nutrition MD suggests glucosamine sulfate, 1,500 milligrams a day, and chondroitin sulfate, 1,200 milligrams a day. Usually they're sold in a combo. There's even something called joint juice, which I've seen in some of the stores. And so that's an area that needs a little bit more research, but incidentally I've had people report that it's been healthy. or helpful. Reducing serum cholesterol, decreasing osteoarthritis risk. This is one of those things that you don't necessarily intuitively think, wow, I'm going to reduce my cholesterol and that's going to help with my cartilage. It makes sense in the fact that when folks have higher cholesterol, they tend to have blood flow that's not quite as good to these areas, and the joints in particular are very sensitive to damage and inflammation. So, for example, the knees are one of those body parts that people very often will come to me and say, yeah, when I was a teenager, I twisted my knee on the basketball court, volleyball, or I just stepped off the curb funny or something and had a bad injury to the knee, and then it got better, and then years and years later, all of a sudden they step on it funny, and next thing you know, the thing is swelled up again and causing pain for a few days or a week or something before it starts to get back down to its regular baseline. It's very typical for those large joints to be sensitive, especially the knees, in that regard. And for that, there really is no cure other than just maintaining good health and good muscle strength over time so you don't accidentally twist things. And one of the things that the cholesterol can be related to that is Dr. Greger has this beautiful video on basically preventing the leading causes of disability. And as mentioned, arthritis in the knees, the hips, the spine, etc., is one of the leading causes of disability as well. And he reviewed some research that showed that when people have a high cholesterol diet and other risk factors like smoking and other things that leads to atherosclerosis or hardening of those arteries, then they're really much higher risk, especially in the spine, is what he used the example of having that wear and tear arthritis. Why is that? Well, the cartilage, that wonderful white stuff that lines the ends of those bones that are in those joints, well, that is a very delicate tissue, and there's really not a good blood supply to it. So all the nutrition that that cartilage needs to thrive and stay cushy and do what it needs to do without getting degenerated has to go to the circulation like a little ways away. So if this is the end of the knee and there's like, I'm trying to illustrate this here, like this much fluid, and the edge of the blood supply is like out here and around over here, well, if that blood supply to these areas surrounding the knee is poor, then there's not going to be as much oxygen, as much nutrition, and all of that kind of stuff floating across that fluid and getting to that cartilage itself. And so the discs in the back, for example, if the blood circulation that goes to the spine is compromised because you're smoking cigarettes, again, if you're using tobacco of any sort, please get off of the stuff. It's so damaging in so many ways, you have no idea. But basically, if those arteries are compromised, then there's a much greater risk for wear and tear arthritis and dementia and all sorts of other things as well. But since we're talking about osteoarthritis today, that's another consideration. So things that keep those arteries open, not only do they help you live longer and so forth, but they also can help reduce pain and prevent a lot of pain as well. So listen up to those that are younger, because things you do today, you will thank yourself for hopefully in 20, 30, 40, 50 years from now. Your body will be much different depending on what kind of lifestyle habits you develop now. Next, vitamin D and osteoarthritis. So we are in a day and age where most people are spending a lot of time indoors. So artificial lighting, hi Deep D, artificial lighting does not provide you vitamin D. There's no UV light or anything. Even if you sit next to a window, that glass blocks all the UV light that stimulates the skin to create vitamin D. I usually do not recommend dietary sources in general of the vitamin D because most people think when they think, oh, I'm going to have vitamin D in my diet, I'm going to drink a ton of milk, which unfortunately is a lot of people are lactose intolerant without noticing it. It also is trouble on the other systems as well. I'll have a whole presentation on how troublesome dairy is to the body later, hormones and all sorts of stuff. But leaving that aside for the moment, good sources of vitamin D, the best is getting a little bit of sunshine. So the amount of sunshine varies a little bit based on the level of natural sunscreen that the body has. So the fairer the skin, for example, if someone's albino, they can hardly tolerate any sunlight at all. They go outside and they get fried, essentially. They need to be wearing a lot of sunscreen a lot. And then the darker the skin tone, the more natural sunscreen is already present in the body, and so they need a little bit longer of exposure to the sun. So generally speaking, some amount of sunshine, between 15 to 40 minutes a day, and not just exposing like a little tiny bit of skin here and such, because again, a lot of people, especially if you live at northern latitudes, you know, you're going outside, you got a hat on, you got, you know, covered head to toe, and maybe like 2 inches of skin showing. And that's not going to make you very much vitamin D. And even at that, in certain times of the year, where it's dark all much earlier than usual. I remember in high school, because I grew up north in Massachusetts, you'd get out and like the sun would be going down at like 3:30 or 4 o'clock, and man, geez, there's no way you can get some significant sun exposure in the winter months if you're indoors most of the time. You have to kind of work at it to do it. Anyway, so this is one of the few vitamins I do recommend a little bit of supplement. Dr. Greger's got this beautiful series talking about the amount of vitamin D that's recommended and so forth. But generally speaking, 1,000 to 2,000 international units of vitamin D tablet a day can be helpful. Some people, just like us, that we manufacture that vitamin D through a reaction that happens in our skin. Mushrooms also will do that as well. So certain companies have taken advantage of that, and they put their mushrooms under sunlight mimicking light bulbs, and they create vitamin D in their mushrooms directly. And so if you want to use those as part of your health plan, that can be helpful as well. But that's one of the few vitamins I also do tend to recommend, is a little bit of vitamin D. Because if the vitamin D levels are low, then people tend to be having softer bones just a little bit, and softer cartilage, and that will be a little bit more prone to getting that wear and tear arthritis as well. So vitamin D is also linked with longevity. In fact, it's one of the few vitamins that's been linked with that. So for that reason, I recommend that in supplement form or original sunshine form, especially if you're out there getting a little bit of exercise. Perfect. So more details on that later. And finally, Dr. Barnard in his article has another mention of ginger, as mentioned in the last presentation. So the doses that he reviewed were 170 milligrams ginger extract 3 times a day, up to 250 milligrams of ginger extract 4 times a day. Or you can just simply get some ginger root and slice it up and throw it in your diet somewhere. Some people will take that ginger root and slice a little bit, and in fact, I've got a ginger tea. I guess technically it's more of an infusion when you do it this way, but we'll call it tea for convenience. You take a little bit of ginger, you boil it for 10 minutes, and basically that liquid becomes very strongly flavored with the ginger. If you want to throw a pinch of cayenne pepper into it to clear the sinuses, that's very nice for cough and cold season. But any kind of way that you get the ginger into the body, it can be very helpful. So, alrighty, so that's all for tonight. Just wanted to do a little bit of a talk on the very, very common osteoarthritis. So check out the links. I'll try to put them into both of the presentations so that you don't have to go hunting and choosing for it. And thank you for joining, and thank you for your questions. Have a good night. Bye-bye.